So today,
we have Rachael Wojcik
Wojcik,
on the podcast.
nurse practitioner here in Santa Barbara, started this program at Evolutions at Spa for hormone replacement therapy and taking in this from a holistic functional medicine point of view, I think offering a good service.
Yeah, I do too, because it's similar to what we do in the office. We've taken the area of your specialty and we've added aesthetics.
And she's done it the other way around.
And they've done it the other way around. They were doing aesthetics and now they've added a hormone program.
Yeah.
But what we're finding is our patients that are using HRT have better skin.
Absolutely.
And it's so much easier for the people that work in aesthetics in the office, like Dr. Pontius and Haley, to treat them and have great results because they're using hormone replacement therapy.
Yeah.
So it goes hand in hand. And I feel like this is just validation to that point, which I really like.
Yeah, I agree.
Yeah, because the multi-specialty sometimes of the office has been criticized by some, but they really do go together.
Yeah.
And
we realized that a while ago.
Yes. And
but some people have been taking time to be convinced.
Yes. So anyway, great conversation with Rachael today. We hope you enjoy the episode. Thanks.
All right. Rachael Wojcik, welcome to the Vagina Doctor podcast. It's great to have you here today.
Thank you so much. I'm honored to be your guest today.
Good. That's a good start.
Yeah.
So you currently work at Evolution Med Spa and have been for a few years.
Correct.
You're a nurse practitioner by training, and you've had more training in integrative medicine at the Institute for Functional Medicine. You've been working at Evolution for a number of years, but now you started something bigger and better. And I think it's important to point in this and describing yourself as a fierce advocate for women navigating the complexities of midlife through personalized medicine and lifestyle strategies. I agree with that completely. I see that you do that. We've talked about that. But that's caused you to develop this program at Evolution. So just tell us about that.
Yeah. Well, thank you for that. So the HOPE program is something that we collaborated on, both Dr. Terry Perkins and Brian Perkins, who are the owners of Evolution's Medical and Day Spa in Santa Barbara here. And when I first presented the idea to them, it resonated with them. And we've been working in aesthetic dermatology for 18, 19 years now. Mm-hmm. And there was something missing. And the women that came to us, and we were doing all the latest interventions in regenerative aesthetics, lasers, injectables. And I started to notice that there was a shift between those women who were optimized in their hormones, who had enough estradiol, progesterone circulating through them, that their skin behaved so much younger. And the more I practiced and treated women, I realized that I'm doing them a disservice if I'm not looking at them in a holistic approach, because that really is changing the dynamics of what we're actually trying to do in the aesthetic industry. And when I came out of my nurse practitioner program, I really realized that there was a need to help women in midlife in this transition. But I wanted to find a way to marry those two worlds together with what I'm comfortable with and then what I was seeing in practice. And when I realized that this could be the missing component to what we are really trying to do within our community, we felt like this was the right move to make. And we launched end of last year, and it really has been well received, but there's still a lot of education that's needed to be done when we're talking about hormone therapy to someone who maybe doesn't know much about it or still has trepidations about the safety of it. So when we got started with the launch program, we actually just focused on skin health, and we created a topical estriol cream, which is a very gentle form of estrogen, because we know that the skin has many estrogen receptors on it, and then you can really make a big difference just topically. So that was the first initial step to introducing hormone therapy at a very superficial level that most people would feel very comfortable and safe with. And then once that was launched, we officially launched the HOPE program, which stands for Hormone Optimization for Personal Empowerment. And
Great name.
Yeah.
Yeah.
So when we launched, it was we weren't quite sure what was going to happen, if people were going to receive it well. And it's been kind of slow to move forward, but it's really been great. And it's given me the opportunity to really hone in on what we need to do to make sure that this approach really resonates with everyone and that I have complete oversight in my patients. So it is a concierge type of model, meaning it's a membership. And, I have another practice in Los Angeles where I see patients just by the hour and they'll see me as needed. And I think that that's a great model too. But I love the oversight of having kind of like a family where my patients rely on me. I'm always available if they have questions. And that way I can really tailor their treatments to really optimize them. Because sometimes, as you know, it can take maybe 6 months to really dial in what their doses may be for their needs at that time. And so I ask for a year commitment. And through that year, I feel like I learned so much about that person. I can run comprehensive labs. We do urine hormone metabolite testing to really make sure that what we're doing is the right thing and that they're feeling great in their bodies.
So you started off using estriol.
Yes.
A wise thing to do, absolutely, because it's the weakest of the estrogens, but it's very safe. There are just no issues with breast cancer or even stimulating any type of female cancer. In fact, it doesn't change the blood levels at all of estradiol. Correct. 75 years ago, estrogen was thought of as the fountain of youth. And it was used extensively at that time, and women felt much, much better, healthier, stronger. Unfortunately, there were some side effects from it because it was used on its own. And there was an increased risk of incidence of endometrial cancer in those circumstances. But that wasn't using estriol, that was using estradiol. We've learned a lot since then. We've had some hiccups along the way, as you know, and with the Women's Health Initiative, which put brakes on the whole thing, unfortunately. And finally, we're coming out of the fog with that now, with safer, more complete, holistic effect. So I really think starting with the estriol was a great thing to do. And you're doing what you did, the skin's responding to it. We find that in our practice too. We have 2 plastic surgeons in our practice at Turner Medical Arts, and one of them concentrates on the skin and face. And she's just has had the same experience as you're talking about, of a huge difference being made to the skin. Now, what I'm doing is systemic, but we're seeing that good effect throughout the body and those ways. So it's really, but sounds like now you're into the systemic aspect of it as well. You're not
Correct.
using just estriol.
Right. Yeah. So I feel like once that kind of bridge opened up and the fog cleared over the WHI, all of the misinformation, unfortunately, that really destroyed women's health for 25 years, maybe due to social media and people kind of listening now. And the younger generation is now starting to say, I have a voice and I don't want to end up like my parents and have all of our hormones stripped away from us, because it's our right as women to have that choice, to make that decision whether I want to replace my hormones. And every woman will experience it if you live long enough. So now I'm going to be approaching 40 next week. So this is kind of my generation of perimenopausal women. We really are proactive. So I am seeing younger women come in who are wanting to test their hormones. So even if they're not part of the program, they can still have hormone testing done. And I think that's very powerful, because you may start to have cycle irregularities early on and think that it's due to perimenopause, but it could be due to other factors too. So I think it's really important to do a deep dive and to see what exactly we need to address. But yes, systemic hormones is what I'm delivering in my program and in my practice. And I've been very fortunate to have amazing mentors that have guided me. And I think that there's so much still to learn. So the delivery systems has changed. And I like that there's many options for women. And we know that, transdermal estrogens are going to be a little bit more, safer.
Mm-hmm.
And so I tend to offer a few different varieties. And I have a compounding pharmacist who has just been incredible along this journey. And
Is that who you're using for the topical?
Yes. Mm-hmm.
And just a couple questions about that to interrupt. Do people use it instead of something they're using, or do they use it in addition to whatever plan they're on for their skin?
So if we're talking just about skin rejuvenation on the face, I'll usually have them add the estriol cream as part of their regimen. So if they're using a retinol or a glycolic or other types of skin boosters, I'll still have them use that, but I'll have them do a foundation with the estriol cream.
Okay. So they use that first?
They would use that first.
Okay.
Mm-hmm. Yeah.
With the systemic dosing, are they static dosing, cyclical? How are you applying? What's the transport mechanism?
So I'm a big fan of cycling hormones, and I think that there's a lot of evidence to support using cyclic dosing, especially when it comes to progesterone. I am a big fan of Julie Taguchi and Susie Wiley, and I do think that there's a lot of great thought behind rhythmic dosing. But I think it's hard for some women to want to have a period again after they've stopped. And so I tend to meet them where they are, but I think that the traditional way of dosing, the standard of care is a static dose. You take your progesterone every night orally and you use your estrogen, whether it's a cream or a patch. And I think what's happening is that we're using progesterone as a drug for sleep. And I don't think that that's really how we should be using it. I think when we think about the natural rhythmic cycle of a menstrual cycle, you have your peaks and troughs. And so if I am starting somebody on hormone therapy, if they're still having a bleed, maybe it could be occasionally, I'll have them use cyclic progesterone 2 weeks out of the month and then stop for 2 weeks. I have found that those women that are taking it nightly, at first they'll find that they may have improved sleep, but I think that that's not really the right way to go. Progesterone downregulates your estrogen and androgen receptors. So if we're giving it at a continuous nightly dose, we're actually going to be lowering our ability to really increase our estrogen. And so that's a conversation that I have. And if they're willing to work with me on that cycle rhythm, I think most women are happy to not have to take a pill every night. Mm-hmm. So I do believe in cycling progesterone. And then estrogen creams, I usually use topically. It seems to be the easiest way to deliver systemic estrogen in a way that they can adjust it to where it feels right. So I usually say, let's start with 1 click, and then we can increase to 2 to 3, depending on how you feel. And some women feel like that's too much decision-making, and they're not quite sure what that means. But we know that estrogen fluctuates every day in a normal menstrual cycle. So when we get up to those higher levels, some women just feel great and others can't tolerate it. So if there is any complication with symptoms from increasing the estrogen levels, that's when I use urine hormone metabolite testing to see, is there an issue with estrogen detoxification? Are they having issues with methylation? Maybe they're not utilizing the estrogen in a pathway that is healthy, and I don't have to worry about any oxidative damage and cellular damage. So those are things that we work on together, and I can kind of dial in.
Good. As a side note, I talked earlier about estrogen being used in the last century and the tremendous help that it was for women, but there was this problem of endometrial cancer. Well, my roommate at medical school did some research and came to the conclusion that the reason why the women weren't getting, or menopausal women were getting endometrial cancer was because there was no progesterone. And so he started a study of giving those women progesterone as well. And that's what started the whole replacement of hormone replacement in a safe way.
Mm-hmm.
And he was, I hate to give him the credit for it, but it's true. He was one of the brightest in our medical class, in our class too, in medical school. He's also a great guy. But again, we were talking about being one touch away from Joe Rogan.
Yeah.
I was one touch away from Dave Sturdy, who was the name of the guy.
Oh, wow.
I did it.
I have a question. So it's interesting that you, with your patients, you tell them that they can go a click up, depending on how they're feeling, because this is a problem we have with our patients, because they'll, come in and then Duncan tells them what to do, and then they just start doing their own thing. And so as time goes on.
Patients that don't listen.
Yeah.
Do you have any of those? No, of course.
Suppose then it just becomes like, the whole conversation is, I need to know what they're doing, and a lot of times they don't really even know what they're doing. I mean, they're guessing. Oh, I think I do.
Right.
I know it says that on the clicker, but I think I'm doing.
Oh, I didn't realize it said twice a day.
Yeah. I mean, so there is a lot of back and forth.
Mm-hmm.
It's done completely.
Yeah. So how often are you, so let's just say you start with someone and you go to one click and then you have them go to another click. And then are you monitoring them with serum or urine in between those times to see what's taking place?
Yeah. So I do a comprehensive lab workup, serum labs, twice a year. And I will usually just have them start with the hormones. I don't tend to test before I start because I can take a history.
What they're going to be doing.
I know kind of what they need.
Right.
So I have them start for about a month and then go ahead and test. It's a little bit difficult when you're testing for estrogen in the blood. Depends on when they apply their hormones. If it's right before lab draw, I've had a woman who had a level of 750 because she had just applied her hormones right before her labs. So I think it is important to, explain how it works and how the delivery system when you have your labs done. But as far as what they're needing, I kind of let them feel it out. And if they make mistakes, it's okay. I don't want them to feel like they've ruined anything. But the nice part about having this concierge model is that I'm there to field those questions when they come in. So they can always email me and I respond within a day. And I kind of enjoy that troubleshooting because it is trying to kind of figure out, where we are. And everyone's so different. When we entered into puberty, it was kind of wild and crazy. Now we're exiting. So that needs to be monitored too. And we need a little bit more hand-holding. So I have some patients who really appreciate that. It makes them feel more empowered to know that there's someone who's helping them along the way and they're not kind of out there on their own. But I give them the parameters. So you can go up to 3 clicks and whatever dose I'm writing on the cream, every click is a quarter of that dose. So kind of let them see what that feels like. And if it's too much, then they can dial it back. But sometimes I'll find that maybe they're putting their systemic cream on their face because it made their skin look so great. So we kind of course correct that.
Yeah.
But I haven't really had too many issues with compliance. I think women feel so great right away that it kind of helps.
Really amazing how quickly it can change.
It's the best type of
medicine. I think one clarification we need to get for our listeners is what a click is.
Okay.
We talked about clicks. It's not a click.
Well, yeah, or you have the people with the syringes that squirted all over the wall.
Yeah.
So when you use a compounding pharmacist, you have the option to make a delivery system that you can kind of dial in, or I call it titrate. So they're called toppy clicks, and every click ejects the cream. And so if you use up to 4 clicks, that means a lot of cream is going to come out and you're going to get that full dose that the prescription is written for. And you apply those creams to your forearms, your abdomen, or your thighs. You want an area of thin skin that can absorb quickly. But there are other delivery methods of estrogen.
What's your place of choice?
I like to rotate sites. Personally, I think that if you're applying your creams in one place every single day, you may end up getting some receptor fatigue. So in order to just mitigate that, I say just rotate. Maybe one day use your arms, other day use your abdomen, and you have absorption is different parts of the body. So, if you're just getting out of the shower and you're warmer, you're going to absorb it a little bit better than if you're putting it on when you're cold. Also, people that have hypothyroidism may not absorb it as much if they have a lower body temperature. So maybe they would do better applying at different parts of their body.
Yeah. That's subjective, though. Because I've heard also the other side of that is you should apply your estradiol to one side of the body, your progesterone to the other.
We don't want estrogen and progesterone put on the same side. So, because they're going to compete with each other. But the site can be changed.
Yeah.
But another important point to the creams, and I want to talk about creams more in a moment, but they can be transmitted to other people or animals. And I had one patient really, really upset with me because I upped her estrogen dose and her dog started having vulval bleeding.
But how does that happen? How does that?
They cuddle their dogs. You cuddle your dogs.
I know, but it's never happened.
No, because...
But then you could say, well, now you could find a different place.
I mean, I have boy dogs, but is that what?
I've heard that story too.
No, right. They're not going to start bleeding. That's for sure.
No, I know.
Yeah. But on a serious note, is that a concern for their partner? Or is it a concern for their grandchildren or their young child?
Right.
Yes, you've got to be concerned about it. Yeah. And it's particularly important with the use of testosterone, which we can talk about again in a moment. But it's great to talk to you because we have the same problems with these patients, and they often don't know what they're supposed to be taking. We have it very clear in their chart what they're supposed to be taking, what we've written down for them, what we sent to the pharmacy, but it may have nothing to do with actually what they're taking.
Yeah.
Point about creams. Compounding pharmacies are not under the jurisdiction of the FDA. And the FDA, therefore, doesn't okay anything that they do. I was attending a course with the North American Menopause Society a year or two ago, and they were talking about the benefits of estrogen. And this was the forward-thinking people in the whole ivory tower type of place where they're so conservative and so slow to make advances. They were saying, yes, we should be starting patients on HRT as early as possible, as soon as they need it. And if they're doing well, they can stay with this forever. So they're very much promoting HRT. But they won't even talk about creams. Or if they're asked a question about creams, they're not FDA approved. We don't use that. Well, you're blocking out a huge opportunity for patients to take these hormones safely. And it is, as you said, it is safer. The transdermal approach is safer. And okay, big pharmas got into it they didn't have any money to make out of HRT at all. So they did it by developing a new transport mechanism, which was a patch. And now, they're all doing it, competing with each other, and there are generics. And so the patch isn't quite as expensive as it was initially, but the limited vision that the so-called experts have relative to top compounding and basically trying to deregulate compounding pharmacies entirely. I mean, we use what I think is the best compounding pharmacy I've ever come across, which is Hormone with Harbor Compounding in Costa Mesa. They test every batch they put through they're under stringent evaluation, self-evaluation. But the compounding pharmacies do also have the ability to evaluate practices and quality. And so it's one of those areas where big pharma is really trying to stamp out the opposition, the competition. So.
And it's unfortunate. I think this past year, I've really noticed it more so with the Board of Pharmacy and regulations in California specifically. And other states don't have as much legal parameters as California does.
Mhm.
And so that's been a little frustrating. But I think the issue is that a lot of people don't maybe do well on the standard dosing that the FDA has deemed
Right.
as correct for women to suppress a hot flash, because we're addressing so much more than just menopausal symptoms. We're trying to, prevent pathologic disease that is really making women age exponentially faster than their male counterparts. And the ability to compound gives providers the option to have a dose that is personalized. And, you can't patent a hormone. So there's not a lot of money in that, like
Right.
you were saying. It's the patch is the delivery system. And, North American Menopause Society has their hands tied because they have to practice with what standard of care is. And, and I think that patches can be fine for some and they feel very safe. But I feel like we've come a long way in this past year that they've said that you can now have your hormones for the rest of your life. And just a year ago, my mother was taken off her patch because she was 65 and all her symptoms came back. So I think that we're approaching a different philosophy now for women's health, as we're trying to sustain our health as long as we can, and the ultimate of longevity medicine is hormone therapy. So there are some people who, like I said, don't do well on the traditional prometrium, which is still bioidentical progesterone, but it does have fillers and other byproducts in it that I don't always want my patients to have. And a patch is an adhesive, so it can either cause irritation to the skin, it can fall off, it can be frustrating, and then you're stuck with these standardized doses. And if that doesn't quite work, then you have to write a new prescription and then have that filled and try that out and then test again, versus
Or people cutting their patch in half. That
or
too.
wearing two. But then, if insurance is approving it now, you can't necessarily give them another round of
The
patches.
strongest patch available is not enough for a lot of people.
It's not. So the downside to compounding is that it's not covered by insurance. So there's that factor that there's a cost that comes along with that.
It's not that expensive, though. I don't think.
Well, it depends who you are, really. I mean, I think to spend $150 a month for something that they need and they feel better on it. It's healthy and it's giving them an increased longevity.
That's not that much to spend.
Well,
If you
I think it's
what
really,
you spend money on in a month.
well, that's true.
But I think we're
It
can
I
be.
think it's initial.
And I think we're very conditioned to not want to pay for our health care. We think, well, I have insurance.
Yeah.
Shouldn't have to pay for anything out of pocket. And I think that's the mentality for a lot of people. And I think that that's true. I mean, we should have affordable health care, but there are some that need different options. So, in my situation, I'm not in network. I don't take insurance. And that's really helped me to be able to give so much more to my patients.
Absolutely. Yeah.
And I wouldn't want to do it any other way.
I agree.
Yeah.
Good job.
Now, what about testosterone therapy?
So I'm a huge proponent of replacing women's hormones, and testosterone is a human hormone. So when we think about it as just being a male-derived hormone, we're really missing a huge component of women's health. And we know that a woman will produce 10 times the amount of testosterone than estrogen in her body. We measure it differently. And sometimes that will be a first line in some cases where I'll give a testosterone replacement before I give estrogen. But it depends on a case-by-case basis. But I do have a large amount of women coming to me with their chief complaint is low libido. And although I think we want to jump to testosterone therapy first, I think it's a very multifactorial issue because they are neurohormones, and we have to think about when we're replacing something, are we doing this because we're trying to fix a reason that may not be associated with necessarily low testosterone? But I do like to check for it, and I'm cautious with it because I have made the mistake of giving it to patients who maybe had history of mental health issues, and it sort of sent them over the edge, made them a little bit too irritable or aggressive, right? Because it can.
More male-like.
Correct. Yeah. I mean, if there's anything wrong,
No, I mean, that
But
happened
some
to
women-
me. No, it
Oh.
happened to me. Yeah. I started using it, just the cream.
Yeah.
And then I started feeling really agitated, just more aggressive in my body,
Right.
you know? Not that I was doing anything bad or anything. But yeah, I had my levels checked and they were
Yeah.
way too high.
Right.
But I felt great besides
Mhm.
that.
Well, I think testosterone is really interesting because the normal levels don't actually change very much between the reproductive years and menopause. So, and the blood levels that pretty much everybody who's using testosterone shoots for in replacement for a patient is way higher than any of these. So I look at it more as a supplement.
Mhm.
And I don't really
Yeah.
look at it as replacement. As a supplement, it could be, obviously it's a controlled drug. You can't call it an over-the-counter drug, but I like to look at it as a supplement. But let's get the estrogen and progesterone right first, as you were describing, and then move into the testosterone boost. And it's really a profound difference for the patients to experience, but it also is above physiological level.
Correct.
So, and a company that's made, a career, a fortune on this is BioT.
Yeah.
And with,
It's like a cult,
It is.
right?
They almost got me at first, and then I thought, well,
Yeah.
good for you.
Yeah, they almost got him too. They would have been thrilled, but
Oh,
yeah. Well, when you have to have a whole plan to mitigate the symptoms and side effects of overshooting it, I thought, well, that's going to be emails that I don't have enough time to respond to so late at night. So
yeah.
I figured
Yeah.
I'll just, go low and slow. But, there are
Yeah.
some women who will convert their testosterone to DHT, which is a much more powerful form of testosterone. So you do have to be cautious. And even women who are in menopause, if they had PCOS when they were younger, I still see very high androgen levels. So, it is important, even though you think, well, maybe she would benefit from it, to test before you decide to jump in and give somebody a hormone that can really cause some trouble.
I want to go into a little bit about the urine testing.
Oh, okay.
Because we don't do urine
Oh.
testing at the office, but it interests me. So can you
Yeah.
kind of walk us through that?
So I find that it's a critical component to my whole person assessment of these women who are experiencing hormonal changes. And when you are doing a urine hormone metabolite test, you're actually looking at what the body's used instead of what's in serum. When you're doing a blood test, you're going to have hormones that are bound to protein that's not usable, and some that's free floating, but that's not what's actually in the tissue. So it's very hard to tease out what's in the tissue. What is she actually using versus what's free floating? So a metabolite test shows us what she's used, and it gives us a 24-hour snapshot of all of the sex hormones, the androgens, different organic acids, and cortisol. So those are huge factors.
So what is the test, though?
So that it's called the Dutch test. It stands for Dried Urine Test of Comprehensive Hormones. And it's really simple. They do it in the comfort of their own home, and you just urinate on these little pieces of paper, let them dry for about 24 hours, and then you send it off to the lab. And from that,
which lab are you using?
so the company that I use is called Precision Analytical. So it all gets sent to them, and you have your results in a couple of weeks. And it's such a great snapshot of where they are in that moment in their life. And you can see if you're giving a cream or a patch or a pill, you can see how they're utilizing it. And if I'm optimal, or if that's going down a pathway that maybe I need to course correct. So when you're giving any type of hormone replacement therapy, the body has its own mechanistic way of detoxifying that hormone. So I would say whether you're taking it or you're making it, it has to leave the body. And the liver is exponential in that whole detoxification pathway. And in some cases, I can course correct whether there's a woman who has a pathway that's maybe more pro-carcinogenic, and not that that's her fate, but if there's a preference for an estrogen that's more oxidative or reactive, I can see that, and I can help with supplements or lifestyle choices to shift that into a better detox pathway. And I do like to kind of test my theories. So I have some patients that are actively dealing with breast cancer, and I have them do a Dutch test. And I do see a powerful preference for a more oxidized type of estrogen pathway called the 4-hydroxy pathway. And she had gone elsewhere to have hormone therapy, and without even checking her detox pathway, she was just given a standardized protocol. But what we were missing was how we can redirect the hormones that she's taking so that she's not going to have, any issues or recurrence too soon.
Well, how do you do that, though? I mean, how do you?
So in order to detox your hormones properly, to redirect that pathway, we have to look at certain cofactors. So things like sulforaphane, which comes from brassicas or green vegetables, broccoli, very, very powerful. So I'll have my patients either take a supplement or increase their green cruciferous vegetables.
So it's lifestyle changes.
It can be dietary. Maybe we're looking at, there's poor methylation. So that's how we're able to make or deactivate or inactivate those compounds and make them water soluble. So maybe they need folate or B12, magnesium, glutathione. So those are all ways that we can support the detox pathways. Now, the issue is that it's usually a genetic predisposition for certain pathways of hormone detoxification. So some of that is what you've been given, and other ways we can mitigate that is lifestyle. So that's what I find really powerful. And a lot of times if I have a patient who's coming to me with some sort of pathology or issue, whether it be endometriosis or PCOS, that's another great case use study for using a Dutch test, because I can diagnose, I can course correct, and really dial in and kind of help mitigate some of those symptoms. So every patient in the HOPE program has a Dutch once a year.
That's great. Yeah.
I've
interesting.
I have been associated with people like yourself who do the Dutch test. I've never liked it very much because of the time frame. I've always wanted to take a specific what's happening today on this patient, and I want the results as soon as possible because of doing a course correction. So there's definitely a choice for providers to use one or the other or both. I've just felt that serum levels have been exactly what I want.
Yeah.
And getting that information that way, because we're getting a huge amount of information either way.
Yeah. And I'd like to use both. So I'll compare my serum levels to my Dutch report. And usually they're pretty close, but there's things that I can get from a Dutch that I can't get from serum. And it can get expensive if you're running a whole slew of labs trying to look at the adrenals and everything else. But when I'm doing a serum panel, I'm looking more at her metabolic markers. So I do an advanced lipid panel. I'm looking at what her fasting insulin is and full thyroid panel. I love the Cardio IQ panel from Quest. So I have
They have the best labs, I think.
They do.
Quest.
And I love the way it reads. So now when I see someone, I look at them either red, yellow, or green.
It's so true. I know.
Color coordinated. Okay.
I know. When you scan your results, you're just looking at.
You don't need to look for just red anymore. You want, because it's not just a red letter; it's a red.
It's a block of red. It haunts you.
But some of those lab markers, my parameters are a little bit tighter, so I like numbers that maybe will prevent more of that red occurring in those reports. So I'm a little bit more strict with my patients when it comes to their metabolic, disease and insulin resistance. And I think when we're approaching midlife and menopause, so much changes. And when you have a steep decline in your hormones, we see thyroid start to, go up. And I have a lot of patients who refuse medications. They don't want to take anything for cholesterol or even thyroid medication. So when I get them on bioidentical hormone therapy, I see those numbers get much, much better.
It's really interesting how socialization of beliefs affects patients positively and negatively. How they hear the word hormone replacement and that's a death sentence. Estrogen's a dirty word, although estrogen was never the problem.
Right.
It's
Statins are like that.
Exactly. Statins are like that. And people, and my best response to the patient, I've been on a statin for 25 years. Okay. I'm here because I'm on a statin. And there's so much. I had a patient once who did a bone density study on her, and it was terrible. She had, high risk for fracture, and fractures postmenopausal often ultimately fatal. And I wanted to, this was probably 20 years ago, 15 years ago. And I said to the patient, look, you need to be on some medication for this. And this is really serious for you. And she said, no, I've just spent a lot of money on dental work and my jaws. And I've heard there's this complication with the medication that we use for bone strength or bone density and the occasional facial necrosis that can occur with this medication. I don't want to be on it. So your chances of dying because of your osteoporosis are way higher than the minute chance you would have of this complication from this procedure, from this medication. And it's just that patients need to be educated gently, but sometimes you just can't get through. You can't prevent those things or encourage them to take things that, or successfully encourage them to take medications. It's difficult, and it's not black and white. I understand that, but some of it really is kind of black and white.
Well, I think you have to meet them where they're at. And, if I have a patient who wants to try to do diet, lifestyle interventions, and just maybe she's open to doing, hormone therapy, I'm happy to help move her in the right direction and show her the improvements. But sometimes you do need to have a stronger approach. But I find that a lot of people come to me because they don't want to go down that pathway, and they're pretty adamant about that. So that's kind of what I'm used to. And, I think you can make a lot of improvements in your, serum markers and overall health trajectory. I mean, eventually if something's going to get us, so I think we can. Yeah.
It's the only thing we're sure of.
Yeah, exactly. So, I think if we can just optimize our health at this time and try to just, mitigate side effects and improve quality of life, I think that really is empowering for women. So I kind of just let them make their choices. They're grown adults, and if they choose to do things on their own, and I'm there to support them. So I'm kind of like their cheerleader along the way.
Tell me about what you're doing in Agoura Hills.
So I have been very fortunate to be connected with some really great colleagues. And in Agoura Hills, I work alongside Dr. Robert Croque-Mall. We have a functional integrative practice, and I've been with him now for close to 2 years. And I was first kind of drawn to the whole world of functional integrative medicine when I did my rotations out here at Sansum Clinic, and it was my first experience working in an insurance-based model. And I thought, this is just not for me. I needed more time with my patients. And then I had spent about a year with my mentor, Dr. Margaret Peterson, who's a family practice MD in Ventura, and I split my time with her, and that was another insurance-based model. And I just remember coming home and feeling so overwhelmed with charting till 1 a.m. And when you're working in insurance-based care, you get reimbursed for how sick people are, and so that is ultimately what's driving the issues with the healthcare model in the U.S. is that people need to be sick for providers to be reimbursed. And that just never resonated with me. So I really sought out, what is the root cause of these illnesses, and how can we prevent this from happening to people and getting to the point where they're already sick. So when I joined the practice, that was, my philosophy, but I also had a passion to want to help women because I knew that this was approaching my life. And so I thought, well, if this is important to me, this has got to be important to all the other women who I'm going to be working with. So in that office, I'm there 2 days out of the week, and I see patients across the lifespan. So my training is in family medicine. So I see anywhere from young teens to older patients, both men and women, and they're coming to see us to kind of optimize their wellness. Maybe they have an autoimmune condition, thyroid issue, GI complications, things that are maybe they're not getting at their traditional medical offices. And so they're using us as an adjunct to try to support what they're dealing with. So I see a lot of really complicated cases, but very rewarding when you start to see improvements. And my foundation is through the Institute for Functional Medicine, where we really take that root cause approach and looking at, why are we having these symptoms? And if we can course correct through diet and lifestyle changes, that can really make someone just feel so much better. And then throwing in some hormone therapy to help support what we're missing has been so rewarding. So it's been really a great experience.
I agree with the point you make about the benefits that we get from our patients. The success with them, patients feeling better, patients being healthier. I mean, that's worth it all. I mean, I feel like I've been incredibly lucky choosing OB/GYN as a subspecialty. And when OB became a little too much stress, and my patients were getting older with me, then menopausal medicine became more important to my practice. And it's been incredible. I mean, OB is obviously a happy specialty almost all of the time. And then even there was a time of doing a lot of surgery, and that was really rewarding as well. But now, again, I've got happy patients. I love seeing new patients. I love getting that problem to deal with and resolve it.
Yeah.
It's not that it's immediately resolved and I never need to see him again. It needs to be continued. But I feel really, really appreciative of what I've found myself in. Can't say that I really chose this because it was going to be a great looking after menopausal patients when I was 23. It's actually it's pretty shocking when I look at it and I think of my roommate from medical school. We were 20. We went to started medical school at 18, and we had a license to practice by 23, and that's a long, long time ago. So,
and that's a huge responsibility, I think. So,
I know.
I mean, for me, this is my second career. I had no intentions of going into medicine or healthcare when I was in my 20s, but I was kind of found myself falling into it. My first passion was hairdressing. I was a cosmetologist for like 15 years before I even decided to go back to school for the first time. So I had my own business. It was a thriving business, and I just loved it. And I was able to, have that same feeling of making women or people just feel so good in such a short time that I thought this is just the best thing ever. And I feel like that now because I'm sort of in that same role of having that one-on-one interaction and being able to give somebody that sense of well-being.
Yeah.
I feel like when you have a great haircut.
Yeah, but that's a big career change, though.
Huge,
You
yeah.
had to go back to school.
Well, I had actually never gone to college before. I went straight to beauty school when I was 16.
So you had to just, how many years did that take?
I was in school for close to 10 years.
Yeah.
Yeah. And I loved every minute of it. I just thought it was so great because I didn't have that experience when I was younger. I was very much an adult, very young. So I think that, you kind of lose that sense of curiosity and wonder that you get when you're going through a rigorous education program.
Mm-hmm.
But I had that business acumen, and I knew that I had a great gift to give, but I had to reinvent myself. But it wasn't because I wanted to. I found myself very sick from all the chemicals that I was exposed to.
Oh, yeah.
And it got to a point where I had to wear a hazmat respirator on my face for years to just be able to work in the salon that I was working in.
Yeah.
And so, come to find out now that a lot of hairdressers end up with bladder cancer because I think that's how your body detoxes all the chemicals. But I was very successful, very busy in my early 20s. And by the time I was 29, I couldn't even breathe anymore. And it was a huge shift. And I didn't really know what I was going to do. And I my husband at the time said, why don't you just go back to school and start over again? I thought that's a crazy idea. I'd never want to do that. What am I going to do?
It's way too much work.
I have hundreds of clients who rely on me, and it's a very big role. So I gave it all up and I went to school and haven't looked back since. And just has been an amazing journey.
Well, I was kind of amused at the response to the letter that Karen sent to you. You had other choices too, as a musician.
Yes. I was a performing musician at the time in a rock band.
But you're classically trained.
Well, but I hated it. When I was a child. So
Yeah.
I'm kind of a rule breaker. If you tell me to do something, I'm going to do the opposite. So if you want to get me to do something, tell me I can't. And that's how I ended up here. Because it was kind of like, I don't think you can do this. Well, let me show you I can. But when I was younger and I was forced to learn how to learn music theory and play piano, I really hated it. But I loved the idea of being creative and doing my own thing. So I retaught myself how to play guitar, and I loved performing. And so I was in a rock band when I met my husband. He says, "What do you do?" I said, "No, I'm a musician." So that was great. And I think that, we all come from some, interesting way that got us here. It's like, how did we decide that this was our passion? And for me, it was the health is the most important thing to anybody. That's
But there was another option for you too, as an artist.
Yes. So I was at a crossroads. I thought, well, I could either become a professional painter. So that's what I was doing. I was hairdressing, painting, and playing music, very creative, or go back to school. And the paintings were doing well. And then I realized that I don't want to be a starving artist the rest of my life. And I had a painting that didn't sell. And I thought, well, I'm just going to go to school and see what happens. So I made that a choice. And that was it. I hung up the paints I haven't painted in 10 years.
Wow.
Hopefully that's a hobby I can go back to.
Well, it's been great having you on the podcast.
Yes. And you found your passion for sure.
Yeah,
So that must feel good.
Oh, it's amazing.
Yeah. You'll never regret that time in school.
Right.
Yep.
No, I highly encourage anyone considering going back to school to think about healthcare. We need more providers.
Yeah.
Well, thanks for listening. We're getting really good feedback. We'd really appreciate a review on Apple Podcasts, Spotify, or wherever you're listening. Thank you. You can always DM the Vagina Doctor Instagram with any questions or topics you'd like to learn more about, or email us. The Vagina Doctor Podcast. It all starts here.